Good evening, America. Guess what time it is? Straight up 5 o'clock on the Gulf Coast, which means 6 o'clock on the East and 4 o'clock in the mountains, 3 in the West. And it is time for Fertility with Fink. My name is Dr. Randy Fink, and I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida, where the Gulf Coast is a beautiful place. The food is even better, and the people are even finer than that. So nice to see all of my friends here as we are every Tuesday evening at this time, where we come together to talk about all the things that are important to us, talking about making families, talking about fertility treatment, talking about women's health, talking about IVF and embryo transfers and endometriosis and all those things that are on our minds tonight. How's it going? How was your weekend? Hope your week is shaping up well. I want to throw out a very special birthday wish to none other than JB Fink, my son, who turned 17 this past week. 17, and my goodness, the time goes by so fast, so fast. It was just yesterday that he was a little tiny chubby boy, and now look at him going into his senior year in high school, and wow. So all I can say is wow. Hi to Tracy. Nice to see you. We've got some different feeds over here. We've got New Life Fertility. We've got Randy Fink MD Instagram feeds right here. We've got Facebook and YouTube and LinkedIn. So if you've got questions tonight, please throw them our way. If we can't get to your questions tonight, you can always feel free, or if you're uncomfortable, you can always feel free to email those questions to askfertilitywithfink@firstfertility.com. Those questions will be taken at the top of the show next week. We'll get to those if we can't get to you tonight, or if you would prefer to ask questions that way. Hello, Toria. Sharmilla, good evening. Thank you for the birthday wishes there to JB. And Sharmilla has a very exciting business going on here. Sharmilla is going to be induced today. An induction of labor today for Sharmilla after a very long road. And I can look back and say, I knew you back when, right? Maybe I can even meet your baby sometime and say, I knew you when you were this big. Wow, this is very exciting. So an induction of labor is, sounds like kind of an exciting thing. And if you've been through it, you know that, well, eventually it gets exciting because there's a lovely parting gift after that induction. But there's a lot of sitting around not doing a whole lot while waiting for the cervix to ripen or waiting for the uterus to start contracting. So not so much drama in the beginning. I imagine you're just kind of doing a lot of hanging out right now, Sharmilla. Sherika Nation, hey, from Jamaica, one of my favorite places. I lived in Jamaica, believe it or not, for a year back a very long time ago in the Kingston area at the university. And some of my best friends are actually located in Montego Bay, even as we speak. Hi to Ross Johnson. Hi, Andre. Good evening to you. Kemperling Preservation. Hello there. Mrs. Vince, it is always a pleasure to see you from Kentucky. Kentucky's been getting all kinds of bad weather, and so our thoughts do go out to all of our friends who are affected by nature and all that Mother Nature is throwing our way. Why, for a time we had fires in the West. We've got flooding. We've got just all kinds of in Texas and up through the mid-Atlantic, and lots of scary things happening. We're also entering hurricane season here on the Gulf Coast, and you may know that I came here from Colorado, where I was for several years. And Colorado, of course, we have to worry about wildfires because they, in fact, even where I was living, I believe many of the insurance companies were going to stop writing homeowners policies just because of the fire risk. But of course, before Colorado, I was in South Florida, in Miami, and the Florida Keys. And so, every time there was something that happened in the tropics, of course, we were the first ones to have a target on us there. So I'm not sure we can ever truly avoid all that risk. All we can do is hope for the best and live each day. Hi to Angela Sack. Thank you for being here as always. Appreciate it. Nurtured Shanna, good evening to you as well. Rosa, thank you for your kind wishes as always. Mag Scamboard, thank you. And hello, Blaxican Beauty. Always nice to see you as well. Mag Scamboard asks, should everyone be on an aspirin for a frozen embryo transfer? And my answer is that there is very little reason not to be on a baby aspirin. So baby aspirin does a bunch of things for us. Most specifically, it helps to kind of thin the blood. So to some extent, it's helping the blood flow that's going through the small blood vessels to supply the placenta and the uterus. In fact, in some cases, when folks are having a difficult time getting the lining of their uterus to thicken up, we'll use some extra aspirin over the course of a couple of days instead of just something like estrogen. So I think there's very few reasons not to be on a baby aspirin, at least a baby aspirin. Additionally, an aspirin is one of the, really, as far as I can think of, the only interventions we know that can prevent certain types of, or make prophylax against certain types of hypertensive disorders in pregnancy. So I think, yeah, it makes a real good sense to be there on a baby aspirin. Black Skin Beauty asked, happy almost grown birthday to my son. Thank you. Let's see. I do want to mention, Angela asks, last week I talked about Alexis Reyes. Alexis is a psychic who joined for a brief couple of minutes. And I looked and I couldn't remember the website last week, but if you will Google Alexis Psychic Boutique in Miami, that's who Alexis Reyes is. And she is an extremely, extremely gifted and talented person, and is also probably one of the most wonderful souls I've ever met. So strongly recommended there. Rosa says, do you recommend pregnancy at 43 years old? Do you recommend in a pregnancy at 43 to get an induction before 40 weeks if there is no preeclampsia or known complications? A lot of doctors feel like, based on what we'll call advanced maternal age, or what we call in the fertility world advanced reproductive age, that it makes sense to not stress the placenta by letting it continue to grow. So we know the placenta is an organ, like any other organ in the body, but the placenta has a limited lifespan, right? And that lifespan is, of course, predicated upon a 40-week pregnancy, 40 weeks being the statistical likelihood of what we call the due date. Now, it doesn't expire at 40 weeks, but considering that when we are older, we expect that we have some difficulties, some increased issues with blood flow, particularly in the small blood vessels. So atherosclerotic heart disease, for instance, doesn't happen in young kids. It happens in adults as we age. So since we know that based on aging, there is an increase in the risk for blood flow problems, the thinking is, well, why test that blood flow in the placenta of an older mom, especially in a mom who has undergone IVF or who has gone through, significant fertility treatments that it's taken a lot to get you to that point. So many people would say, yeah, you know what? I think it makes sense to induce labor at 39 weeks. Now, there's been a big push in the obstetric community to not induce labor electively prior to 39 weeks, which would be 1 week before the due date. Why is that? Because even in those what we'll call near-term deliveries, there is still an incidence, a higher incidence of babies having to stay in the NICU. Babies having a difficult time doing the things that babies have to do when they're born. They have to figure out how to breathe the air on the outside, right? Because the air, because what they're breathing on the inside, they're not breathing air. They're getting their oxygen through blood flow that's coming through mom. So they have to figure out how to breathe on the outside. They have to figure out how to stay warm. They have to figure out how to regulate their blood sugar. So all these kinds of things a newborn has to do. And these are some of the things that become challenged when babies are very little and they're in the NICU. So the push is towards, well, if you're at term, if you're at 37 weeks and there's a medical reason to induce, then by all means, the medical reason takes precedence there. But assuming there's no other medical indication like blood pressure problems, growth issues with the baby and so forth, everything else being equal, if you make it to 39 weeks, we know that those babies do just as well as babies at 40 weeks and potentially even better than those that go post dates, and that is to say, after their due dates. And so that is probably the rationale, Rosa. Now, different doctors feel about it different ways. Some will say, I'm not going to let you go past 39 weeks. And some will say, I'm not going to let you go past your due dates. Most will say, I'm not going to let you go more than 1 week past your due date. So it really depends on your hospital's policy and on the way your OB feels about it and what their standard practice is. But that's really the rationale behind it. It's so that we don't add extra stress to an already challenged placenta and the blood flow. Let's see, can an epidural for vaginal birth cause chronic back pain? And the answer to that is no. I have never really seen that to be the case. So when I was practicing obstetrics, it was not uncommon for someone to come in after their delivery and say, my back is hurting me, and I'm pretty sure it must be because I got an epidural. And I'd say, no, I don't really think so, because the truth there is that epidural related complications are typically, if you're going to have a complication, and fortunately complications with epidural anesthesia, they're not zero, but they are very rare. The most common is your blood pressure can drop. And if the blood pressure drops a little bit, well, that can affect the blood flow to the baby. So sometimes after an epidural, we'll see the heart rate of the baby sort of temporarily drop down. And that's something that's easily sort of fixable. But serious complications from an epidural would be things like, a nerve injury where you're paralyzed. And again, fortunately, very, very rare that something like that happens. Back pain as a result of the needle going through your skin really is not so much a thing, I don't believe. The issue, I would say, when folks would come in and say, I had a delivery and now I'm having all this back pain, is, well, remember, first of all, when you were in labor for however many hours you were pushing to get the baby out, your feet were back behind your ears. You were literally folded up so that your pelvis could open, so that the baby could have some room to come through the bony pelvis and the birth canal. And that's one thing. But don't forget also the very clear reality of the fact that when you are pregnant, your center of gravity dramatically changes. We are bipeds. We walk around on 2 feet instead of 4. But remember that we probably evolved from creatures that walked on all 4s. And so now our back has to do a great deal of work just to keep us upright, just to keep us standing and to keep us moving. So when that's the case, and you're pregnant, you've got all this extra weight, all this extra size that is sitting in the front. And so your center of gravity has very significantly changed. So not surprising that many of these little muscles that never really had to do much else beforehand are suddenly really having to deal with holding you upright. And so is it any wonder that back pain is a real problem in pregnancy? And then you have a baby. All right, so you go through the labor and delivery process. You're probably not exercising and strengthening your core very well after you have the baby because you're dealing with just kind of trying to be a mom and trying to adapt to the world around you and the changes in your body. That now that change in the center of gravity is gone, your back is having to strengthen many of the muscles that were getting supported by other muscles. And so it's no wonder there's back pain. I think that an epidural for vaginal birth is probably not a realistic cause of ongoing back pain. And I'm sure if we have any anesthesiologists or anesthetists out there who want to chime in, my guess is that I probably just, captured the reality there. Hey to Mary, thank you for being here. And G172, how are you this evening? Marlena B, thank you for being here. Blaxican Beauty asked, should I get another saline sonogram before my frozen embryo transfer? My last saline sono was in October of 2024. I would say, we like to evaluate the uterine cavity once a year. So October of 24, if you have your FET before October of 25, I would say, no, I don't think you necessarily really need another saline sonogram or a hysteroscopy or some other evaluation of the cavity. Typically, one evaluation of the uterine cavity is pretty much good for a year. All right. Hello to Beth. Angela asks, what would cause your estrogen to stay elevated after an IUI without taking any estrace? My estrogen was 1247 2 days prior to my IUI, and then 1144 at 7 days after the IUI, which I found to be very high. Well, so remember where that estrogen is coming from. Where do you get your estrogen? Well, your brain is looking for estrogen. It wants estrogen. It knows that you need estrogen. So your pituitary gland secretes a hormone that's called FSH. FSH stands for follicle stimulating hormones. What does FSH stimulate? Follicles, hence the name. Well, those follicles, they're not hair follicles like on your head here, but follicles in the ovaries, which are little egg houses. So FSH tells your ovary, give me some eggs. Your eggs in your ovaries are surrounded by some cells that are called granulosa cells. And it's your granulosa cells that make your estrogen. So when your estrogen level is low, like it would be at the beginning of a cycle, your FSH starts to go up, telling your body, give me some more estrogen. As that FSH rises, you start to recruit a follicle in the ovary, which the granulosa cells from which make more estrogen. What does that estrogen do? The estrogen's job is to thicken the lining of your uterus. And that's where you get that nice, spongy, warm, juicy place for a baby to be able to implant. Well, so around the middle of the cycle, when you release that egg, your lining has gotten nice and thick. The egg leaves, and the estrogen factory from that where that follicle was starts to become a little progesterone factory, and that's where your progesterone comes from. That's called a corpus luteum, and that's why it's called the luteal phase in the second half of your cycle. But you still have granulosa cells that are secreting estrogen. Now, what happens over the course of the next couple of weeks? Well, you keep making estrogen. If a sperm comes along, and here's a visual, if the sperm comes along and fertilizes the egg, then you're pregnant, right? And so that little embryo, and that fertilization happens in the fallopian tube. That little embryo works its way down the fallopian tube and implants inside the uterus. And then, well, gosh, then you're pregnant. And if it doesn't, you get the message, oh, hey, not pregnant. The corpus luteum starts to shut down. It turns its volume knob off. The progesterone level goes, and it does actually make that noise. And once it drops down, that's the signal for you to have a nice normal period. So you clean everything out and you say, well, I'm going to try again fresh next month. And that's the signal for your nice normal period. But so you had some estrogen there, and so I'm guessing, Angela, maybe you had a natural cycle. Even still, if you did a medicated cycle, we gave you some estrogen, but your granulosa cells secrete some estrogen, and so it's not strange that that estrogen level stays elevated. Hi to Jamie Marie. Hello to Nina Buena. Nice to see you, Sue Fraser. Oh, is that really Sue Camp? If you're still on there, it's very nice to see you this evening. Thank you so much for joining, and please send my regards to Katie. Mag Scambor says, thank you so much for answering. What would you say is the best FET protocol for someone with stage 4 endometriosis? Okay, so endometriosis is a bad actor. You know what endometriosis is, right? Endometriosis is where that lining of the uterus that normally sloughs off when we have a period, instead of coming out, works its way up inside into the pelvis and implants. And that tissue can then respond to your hormones and start to interfere with the connection between brain and organs. Now, in many people, endometriosis causes a pain syndrome. And so classic symptoms of endometriosis are very painful periods, chronic pelvic pain, certainly pain with a bowel movement or pain with sexual intercourse. Those are the classic symptoms of endometriosis. Do you know what are the most common symptoms of endometriosis? I would say the most common symptom of endometriosis, and the answer to that is nothing. The most common, am I saying that right? Yeah, the classic presentation of endometriosis is pelvic pain, but really the most common presentation of endometriosis is no symptoms at all. There are many people that we may, for example, the doc might go to do a tubal ligation, go to tie the tubes, that a lady has had, 4 babies, she's done with childbearing, wants to have her tubes tied. Put a camera in to go tie the tubes, and lo and behold, oh my gosh, there's endometriosis everywhere. And she does not have a symptom at all. And you say, how is it that she can't have any symptoms from this and she had no difficulty getting pregnant? Well, by then, the same token, someone may have debilitating pelvic pain that we are so certain is going to be terrible endometriosis. And we put a scope in to go look, and lo and behold, maybe there's one tiny little spot of endometriosis. Or, now we can actually test for endometriosis without having to do surgery. We may find that someone is positive for the marker for endometriosis, which is called BCL6. And of course, the test for that is called Receptiva. We may find they're positive for BCL6, and then they go later on, and for whatever reason have surgery anyway, and you can't find any endometriosis. Maybe it's too small. Maybe there's just not enough of it there to visually be able to see it. So endo is a tough one, but we know that from that Receptiva test, that when the endometriosis is positive, particularly in folks who have had a difficult time with pregnancies, and that may be with recurrent implantation failure. You've had a number of embryo transfers that don't stick, or just simply not getting pregnant at all in the general population without having done fertility treatment. It may be because that endometriosis is interfering with the way your embryo is implanting in the uterine lining. So as far as what's the best protocol for endometriosis, I would say, well, the first thing is we know that we want to suppress the endometriosis. And that is that for 60 days, we want to use a medication that turns off the endometriosis food supply, which is the hormone. So the 2 different medications, or really 3 different medications we use for that. Lupron is the oldest. Lupron is still probably the most common. Lupron, as you probably know, is a shot. You get that shot. The shot can last for a month. There is also a 3-month version of the shot. I don't recommend that 3-month version because you're treating it for a month longer than you really need to. And it's not that, oh, if you treat it for 2 months, then treating it for 3 months must be that much better. The evidence shows that 2 months is really all you need in terms of treatment. So, I typically do the 1 month treatment at a time, and what that does is that it shuts down the inflammation, that inflammatory marker we find in the uterine lining, and your embryo transfer results return totally back to normal. So we really have learned how to shut off that endometriosis effect in the uterine lining, at least in so much as what we know right now. That's what the science shows us. Now, whether you do a medicated cycle or whether you do a natural cycle really depends. I don't think that either one is particularly better or worse for endometriosis, for instance, and there certainly is no data to show us that one or the other is better in the case of endometriosis. However, what does happen is that if you've done your suppressive medication for 2 months and then you try to do a natural cycle for your FET, I think there's a very real probability that your body is not going to respond in the way you expect for it to. Because even though the Lupron has worn itself off, it still may take some time for your body to kind of return to normal. So for that reason, I think that if you're doing suppression, it's better to do at least a modified natural FET where we are going to make sure that you ovulate. We give you some letrozole so that we know for sure that your body is going to produce that egg. Or quite frankly, maybe it's just a little bit easier to go ahead and do a medicated cycle, because in a medicated cycle, we're controlling for all that. You know, we're gonna eradicate any variable that's involved in your hormones, so that we can completely control that cycle and take away really any question about what your body's going to do. Now, again, I'm not familiar with any data that says that one type of frozen embryo transfer is better than another in the case of endometriosis. And certainly in the general population, we know that that those two things, the natural and modified natural cycle, and versus a programmed cycle, which is the medicated cycle, are at the very least equivalent. So that's my 2 cents worth on that. And hopefully that's a long way to answer your question there. Hey to Mary Lynn and also Mallory, thank you for being here this evening. Dr. Russo, good evening. Thank you for being here. Hello to Zenaida in Miami. Hello to Ms. Andres. Nice to see you here. Haven't seen you for a while. Angelica is here, and it's a pleasure to see you as well. Noodles for Life. Hello, Maxim09. Let's see, Kells Bells, nice to see you. Noodles for Life, and I have to say, I do really like that handle there. My midway FET embryo transfer, progesterone level was at 64 while waiting for my beta. At what point can I reduce the daily PIO and prometrium to either PIO only or just PIO every couple of days? Well, so, you know, first of all, I would say it really depends on the protocol that your clinic is using, because for me, I typically will do a progesterone and oil shot every 3 days and supplement that with some vaginal progesterone for the local effect. Now, remember, the progesterone and oil is what's giving you your progesterone level. The vaginal progesterone that you're using is really just to affect the endometrium or the uterine lining and doesn't measure in your blood. All right, and that's an important thing. A local effect only, not in the blood. So, you know, if if you were my patient and I was seeing that, and I was seeing that we're giving you progesterone every single day, and your progesterone was 64, I would say, yeah, I think it's okay to back down from that. Now, again, every different places do it differently. So I certainly don't want to give you medical advice in a situation where I'm not involved in your care. But I will say that many people do a FET, a medicated or a programmed FET cycle using a progesterone and oil shot every 3 days, really every 72 hours. So I would say not a bad idea. Now, there are some people, since we're on the subject there are some people who will say, I don't want to use that shot. I don't like the shot. The shot hurts. I don't want to do it. All I want to do is vaginal progesterone. And my answer is, well, in that case, I recommend you do a natural cycle or a modified natural cycle, because doing a medicated cycle and not using progesterone and oil will result in outcomes that are far inferior to what would happen if you were using the progesterone and oil. You really need that progesterone. Progesterone vaginally is really not enough progesterone to maintain a pregnancy when your body is not making it at all, which is what happens in a medicated cycle. You're not making any progesterone. We're giving it all to you. So you do want to get some PIO, but yeah, I think every 3 days is fine. A special good evening to Brandis Courtney Montez, my former colleague in Colorado Springs. If you are still on, thank you so much for being here. Appreciate it. Brandis does a podcast now and also has some really wonderful content. So it's my pleasure to give her a shout out and say, if you don't follow her, please do that. Brandis Courtney is the Instagram handle. Hey to Melissa and Shada. Good evening to you, my friend. It's great to see you after a while. We have some aneuploid embryos left. A question comes in here. Is there any chance that a healthy baby can be born out of it? And, you bring up a very big controversy. That question comes from Rosa. And I'll say, I got to tell you, when PGTA, pre-implantation genetic testing for aneuploidy, when PGT first came out, there was this notion, almost there was a promise from the industry that seemed like, wow, this is how you know if your baby is going to be normal. And really the truth is that's not the case with PGT. So when your embryo comes back, so remember what's happening with PGT and how that works, we are biopsying from the outside part of the embryo. That's the part of the embryo that's going to become the placenta. So we're not taking a piece of the baby, we are taking a piece of the placenta. And it is possible for you to have a normal baby with an abnormal placenta. Or vice versa. It is possible to have an abnormal placenta with a normal baby. Now, when you look at the statistics of what PGT does and is supposed to do, it's a suggestion, right? It tells me that, okay, if we have a euploid embryo, which means a chromosomally normal embryo, statistically, that's a 65% probability of achieving a pregnancy and a live birth. If that embryo is abnormal, well, I would say there's probably about a 5% probability or less of having a normal embryo or an embryo that implants and results in a live birth. So abnormal embryos in IVF typically don't implant. So very commonly they will miscarry or you'll just not get a positive pregnancy test. And that's usually the way that happens. But what we see with PGT, and that's really one of the reasons that you see all these lawyers advertising, trying to get clients for class action lawsuits against the laboratories that do the PGT, because they want to make some claim that, there was false advertising, that people were misled about what PGT really means. I like to tell the story of a patient in Colorado who came in and brought her twin boys with her. And both of the, for everybody to meet and everybody, we all gather around, we all took pictures with them. But it turns out that those twin boys were as a result of a frozen embryo transfer of two aneuploid embryos. And guess what? They turned into two completely normal little boys. Now, what are the odds of that? I would say the odds of that are pretty low, but PGT is not perfect. So, there are many folks who will say, well, I want to transfer my aneuploid embryos because, there's a very small chance that they could be normal, but also because I just feel better about placing those embryos back inside me. If I'm going to dispose of embryos, if I'm going to dispose of what is life, whether or not, there's a good probability that life would continue or not, I would rather put them back inside me, where they came from and where they belong. And so that's one reason that folks will transfer aneuploid embryos. There's also something that's called a compassionate transfer. And what that means is that we take an embryo and we place it back inside the female at a time when we know that the embryo is not going to stick, that hormonally it's in the wrong hormonal state for an embryo to stick. That's called a compassionate transfer. That's another thing that can be done. But just because it says aneuploid does not necessarily mean it's a throwaway embryo, but the odds of it being normal are very low. AZ Signatures, hello to you. Stage 4 endo, I have one blighted ovum and one chemical from medicated FETs with Lupron suppression. I'm going to be trying natural cycle next. I like it. I think that makes sense. Shada asks, is there any testing for ureaplasma bacteria and what causes it and how to treat it if you have it? Well, so this used to kind of be a big thing. There are two types of bacteria that can be in the cervix. There are a lot of different types of bacteria that can be in the cervix, but the two in particular, one's called mycoplasma and the other is called ureaplasma. And for a long time, we would routinely test these things in the cervix before we instrumented the cervix in any way, particularly in the fertility population, because the belief was that these bacteria could affect pregnancy and could cause chronic inflammation in the uterine lining, and that they, were potentially a source of infection, as it were. Well, over time, we came to realize that no, it really doesn't so much happen. So there are many people who are just outright colonized with mycoplasma or ureaplasma. So nowadays, in an asymptomatic population, we do not recommend testing for these bacteria. Now, let's say that you do test for the bacteria and you find it's positive. They are considered to be sexually transmitted. Now, does that mean it's a sexually transmitted disease? No, because again, many people are just colonized with these things. These little bugs just live there normally in many people, which means, they're probably not pathogenic. They're not a bad thing. However, what we would do in those days, and this is kind of in the olden days and maybe 10, 15 years ago, we would treat you usually with either doxycycline, erythromycin, or azithromycin. That was the more common treatment, azithromycin. And we would treat a sexual partner as well. And we would say, you both got to take the treatment, and then you're going to come back. We're going to do a test of cure. Well, the problem is that there were a lot of people who never got clear of their mycoplasma and their ureaplasma because those bacteria just lived there. And really, so nowadays we are aware they don't cause the problems that we once thought that they did. So we really don't recommend that people routinely test. Hey to Tiffany and hey to Melissa. Also a special hello to my parents, the Bama Gal and husband Harold, who are hopefully watching from Mobile, Alabama, just a stone's throw from me here. I believe they are watching on YouTube tonight. If you are just joining, it's about 40 minutes or so past the hour, and we're here every Tuesday evening at this time, 5 o'clock Central, 4 o'clock in the mountains, 6 on the East Coast, and 3 on the West. And this is Fertility with Fink, your one-stop shop to learn and talk and just to be together and deal with all these things that are important. Things about making a family. That's what we're doing here. If I don't get to your questions here this evening, or you would rather not ask the question on the live, send me an email, and that's askfertilitywithfink at firstfertility.com. We'll be here for about another 20 minutes or so. Oh, let's see. Amanda Marie, hello, and hi to Sarah. Amanda says, how many days after stopping Orilissa should you schedule a baseline? Is 3 days okay, or should I do Orilissa a little longer? Doing a lot of an estrogen, a medicated FET. You know what, Amanda? I started to talk about this, and then I think I got sidetracked. When it comes to suppressing endometriosis, the only medication that we had for 25 years was Lupron, and I started to tell you about that. There's the 1 month, there's the 3 month Lupron. Well, probably about, maybe 7-8 years ago, maybe even a little longer than that, maybe close to 10 years ago, an oral version of that same category of drug came out, and Orilissa was that first drug. There since came to be another one that's called Myfembree, and they both probably work in a very similar fashion. I personally prefer to use those pills over the Lupron when possible, because they're just tolerated a little better. They have it's a kind of a kinder, gentler way to suppress endometriosis. Lupron, when you take it, literally pulls the plug on your hormones. So it's shutting off your entire hormone supply. It's putting you into a temporary menopause. And you say, ooh, that sounds terrible. Well, I mean, yeah, there are side effects associated with that, and we can manage those side effects. So it isn't the end of the world. But if you can take a pill that gives you a little bit more control, because you can pop a pill every single day instead of having to get a shot once a month or once every 3. Many people prefer that. And when it comes down to it, the number of people who discontinue Orilissa because of the side effects is really no different than folks who will discontinue birth control pills for their side effects. And not to understate the presence of side effects with birth control, because many of you have tried them, have used them, and they make you sick as hell. You don't like them, and I get that. But relatively speaking, birth control pills are one of the most commonly prescribed medications, and certainly one of the best studied in the history of medical science. And so there are literally a gazillion birth control pills prescribed, and people take them very, very commonly. So even though you may not have liked them very much, there are a lot of people who take them. Would you agree? And so the number of people who actually stop taking them is relatively low compared to the number of people who actually take them. And I would say Orilissa really kind of gives you that same sort of discontinuation rate. So I do like the Orilissa, but you're saying you're going from Orilissa into a medicated cycle. So in other words, how many days washout do you need before you think about starting on your estrogen medication? My answer to that is probably about 5. And I say that based solely on my gut feeling. And that gut kind of comes from, well, if you're on some estrogen and progesterone, if you're on some birth control leading up to the start of an IVF stimulation cycle, granted, we're stimulating you in that point with the FSH, but we generally want to give you about a 5-day washout if you're on birth control. And that's a pretty standard thing. So 5 days, I should say, after Orilissa. But the truth of the matter is that in an FET cycle where you're starting with estradiol, we can give you as much estrogen really for as long as you need it in order to get your estrogen level where it needs to be. So, truthfully, it's probably not as significant in that scenario. So, many people would say, oh, you can start it the next day, or 3 days later, or 5 days later. I don't think that there is any specific guideline on that. So for me, I'd say 5 days, just because I try to keep it consistent. But there are many programs that'll say, well, go ahead and start your estrogen for your FET the very next day, and I think that's probably okay too. Hope you're doing well on the Orlissa, Amanda, and our fingers are crossed for you coming up on this cycle. Let's see what else we got here. Hi, Elisita. And Shada says that with the aneuploid embryos, if the body couldn't correct the faulty chromosome, could it be caught during pregnancy, avoiding birth of unhealthy babies due to these chromosome abnormalities? And the answer to that is yes. But I would say there's two things there, Shada. So number one, like I mentioned, it's actually pretty rare that you see a chromosomally abnormal birth arise out of the process of IVF. In fact, in my career, I don't remember ever seeing a chromosomally abnormal birth arising from an IVF pregnancy. And so what I mean by that is that nature has a way of taking care of these embryos before they have a chance to grow to the point where they actually can be viable on the outside. Now, I wouldn't swear that that's true. There's never been a case. I'm sure there has been a case, but truthfully, it just doesn't happen very often. The real question there is, well, let's say that you do an embryo transfer, and let's say that you do an embryo transfer of a euploid embryo. Do you still need to do something like an amniocentesis? And amniocentesis is where we take some cells either from around the placenta or place a needle into the fluid that surrounds the baby. The baby is sloughing off skin cells into that fluid, and so those skin cells have the baby's DNA. So is there a place for that kind of testing in someone who has already put back a chromosomally normal embryo? Well, there's a controversy there, because you could talk to an MFM specialist, maternal fetal medicine, which is a perinatologist. Those are the high-risk obstetricians, and they are customarily the ones who do those amnios, or in some cases what's called a CVS, a chorionic villi sampling, which I think is really a better test because it can be done earlier and you get your results earlier. Some of them would say, well, until you have those actual chromosomes, that chromosomal report in hand, you don't know. I think most people would say that if you did PGT testing on an embryo, that an amniocentesis is probably not necessary. But there are still some specialists who will say, yes, they're absolutists. They want to know, they want to see it themselves from their very own embryo. By the same token, what about NIPT? Are you familiar with NIPT? So NIPT is non-invasive prenatal testing. And those are the tests that can be done and somebody really wisely figured out how to draw a tube of your blood and to be able to shake it up in such a way to separate out maternal cells, your cells, from the baby's cells. And then they can probe the baby's cells for specific abnormalities, usually trisomy 21, Down syndrome, trisomy 13, and trisomy 18. It's really fascinating. It's not a perfect test. It's still considered a screening test, unlike an amniocentesis or a CVS, which is a diagnostic test. So I would not recommend NIPT if you're gonna. I mean, I do recommend NIPT in pregnancy, but certainly if you had it's non-invasive, so could you do it? Sure, but if you transferred euploid embryos, it's just realistically probably unnecessary, and not nearly the sensitivity as is that of the PGT itself. But to answer your question, Shada, if you put in an aneuploid embryo, could you do testing during assuming that that embryo implanted? Right? And assuming that embryo continued to grow, and assuming you've got a heartbeat, and assuming the pregnancy, kind of continued on, could you do testing to see what the story was with that embryo, and whether it was normal or not? And the answer is yes. And that would be either the CVS chorionic villi sampling or an amniocentesis. Good question there. We're getting all kinds of good questions. AZ Signature says, I had 3 IVFs, even with donor eggs. Can I still get pregnant naturally? Well, I think it depends on why you did IVF to begin with. So when you make the decision to go to donor egg, it usually is because most commonly, it's because of age, that the egg quality, meaning to say the stability of the DNA that's in our eggs, starts to become less so as we mature. So the older we are, the fewer eggs we have, and the less stable that DNA is, which are really the 2 reasons that women who are older have a harder time getting pregnant, right? A lot of times people will go to donor egg because of either egg quantity or egg quality issues. And if that was the case, could you get pregnant naturally? Well, I mean, yeah, you could, because, basically what that means is that if you did your 3 IVF cycles and you were unsuccessful in creating a normal embryo, that doesn't mean that you don't still somewhere in your ovary have 1 normal egg. And all it takes is 1 egg and 1 sperm to make 1 embryo. So yes, and I have seen that happen before, where folks have been unsuccessful with IVF. They couldn't get pregnant, and so then they stopped trying, and lo and behold, what happens is they got pregnant on their own. Now, did some of the residual hormones or medications that were used for IVF contribute to it? Maybe so. But, certainly it depends on the age. At 50, I would say it's probably very unlikely that you have normal eggs left. But, could there be 1, 2, 3? Yeah, certainly maybe so. But, even at 43, 44, 45, where it seems like there's no normal eggs, there's still probably a lot. The sad part about the science that we do here is that, we can make you produce an egg for us, and we can retrieve that egg, and we can place a sperm inside that egg and try to create an embryo. But all we can do is to make it produce an egg. We can't select the eggs that we want. We say, oh, we only want the normal eggs. I wish it were so. And maybe at some point in the future, we'll be able to do that, but not yet. Unfortunately, not yet. When do you start progesterone after an IUI? 2 or 3 days after. Different programs do different things. And you asked about Indometrin. Indometrin is a brand name of vaginal progesterone. Some people will use Indometrin. There's another one that's called that I am blanking on at the moment, but it's also pretty fine to be able to use a Prometrium or micronized progesterone, which comes in the form of a pill, and that little funny egg-shaped pill you can just kind of place in your vagina, and it will absorb there really on its own. So Indometrin, the problem with Indometrin is that it's expensive, but I usually start at 2 days afterwards. There are some programs that say start at 3, and I'm not sure it makes a huge difference in terms of outcomes. Hi to JDJD. Nice to see you this evening. So again, we've got a couple of different Instagram feeds. We've got Facebook and YouTube and LinkedIn. If I don't get to your question tonight, please email to me at askfertilitywithfink@firstfertility.com. com. We've got about 5 more minutes here. Let's see what we can answer. Does Prozac impact egg quality or implantation for someone who struggles with depression and needs to be on it? So the answer is no. I have never seen any data to suggest that the SSRIs have any negative impact on either egg quality or implantation. So I feel very strongly that those medications that you should stay on them. Now, normally what I do when a patient comes to me and says, "Hey, I'm on such and such a medication, should I stop it?" I say, "Well, I didn't start you on the medication, so who am I to tell you that you should stop it? I think you should, if you want to stop it, you can, but you should ask your prescriber." Unless there is something, unless it's a medication that's truly known to be harmful. But even still, I would say I didn't start you on it, so I'm not sure what led you to be on that as opposed to anything else. But with the selective serotonin reuptake inhibitors such as Prozac, Zoloft, Lexapro, and the like, there may be some very, very small risk in some populations to the baby. The baby may be born with some irritability as a result of the medication, nothing that pediatricians aren't able to handle. There was a suggestion that there could be an increased risk of certain types of cardiac heart valve type defects, but in the general population, those things are really few and far between. They're very rare. And the risk of you stopping your medication and having really uncontrolled depression or anxiety, creates a havoc of its own. Not only does that feel bad for you, but it elevates your cortisol levels, and those cortisol levels just come from your adrenal glands. Well, that can have an adverse effect on pregnancy as well. So I'm a real advocate of staying on the medication, particularly those antidepressants. Hi to Siciliana Melissa. We haven't seen you around for a while. Nice to see you. Queen Lacido, hello. Amy's Adventure. Hi to Haley Rourke. Amy says, can IUI be successful for a couple that has low motility and morphology? And the answer is yes. Really, the more important. So when we look at motility, we're taking the total number of sperm and really kind of multiplying it by a factor that is the motility. We still want, so that results in something that's called a TMC, a total motile count. We really want a TMC in nature to be above about a 20 million. And what you may have heard me say, maybe I've even said it to you sitting in my own office, is that we're pretty inefficient at reproducing, that it only takes one sperm to get the job done. But in order to get that one sperm there, we need 20 million sperm swimming in order for that one sperm to realistically have a chance to fertilize an egg. So when it comes to IUI, we can deal with a lower total motile count. About 10 million is where I would say is the sweet spot for IUI. Once you start to get a total motile count, that is number multiplied by the number of swimming sperm, that's less than 10 million, IUI outcomes start to drop off. But yes, morphology is one of those things that doesn't really necessarily, we find it in folks who are dealing with fertility concerns, what we'll call a subfertile population, but it's not considered to be a cause of infertility. And when you do an IUI, theoretically, what you're doing is that you're separating out the best and the strongest swimmers. So you're going to place them inside at just the right time so that you maximize the odds of sperm meeting eggs. So in theory, you're decreasing the number of abnormal sperm being there and increasing the number of swimming sperm. But again, I look IUI for not less than about 10 million in order to really truly predict success. Hi, Mohi. Nice to see you this evening. Sonia is here. Fairy Tale. Ashley Atkins. Queen, it's good to see you. I think I just said that. We're going to run out of time for tonight. But as always, this is the place. I sure enjoy being here with you every Tuesday evening. I am fond of saying, and if you've heard me say it before, please listen to me again. Tell all your friends. This is not the book of your life. This is just a chapter. And what are we here to do? We're here to rewrite that damn chapter together. So every step forward with kindness to other people, there is not enough kindness in the world. Every step forward with love, and every step forward knowing that tomorrow is a new day full of hope and full of all new adventures. So until next week, I'm Dr. Randy Fink. Thanks so much for being here. See you next time.